Recording. Okay.
Good stuff. Could
So
we go on to the next slide, please?
yeah, because I need to. There we go. So just a quick introduction to Dr. Whittle. So he's an incoming neurosurgery junior clinical fellow at John Radcliffe in Oxford. After having completed jobs in neurosurgery, stroke medicine, and as we've heard, oncology. Um, he's got a huge amount of experience within the neurosurgery field already, with a master's in cognitive neuroscience, runs a research group which presented internationally in the past 3 years, and has teaching experience in the UK, Nepal and Gaza, and is a reviewing editor for Springer's Nature's leading neurosurgical journals. So we're really grateful to have you. Thank you so much for agreeing to do this talk for us.
Yeah, that's absolutely fine.
So
So,
bit more, sorry,
oh,
a bit about Medics&Me.
yep.
So we're a nationwide charity. We support aspiring medics, medical students, and people post university when they're working as doctors. So we've got teaching opportunities, so you can go and come and teach aspiring medics, current medical students, all your peers. We've got lots of opportunity for QI and research projects, which in your foundation jobs is essential because you need to run a QI project. So getting some experience can be really helpful. We also run a careers blog where you can go and check it out, see what we've got going on and what advice other people have been given. And if you're interested, we always welcome people to come volunteer with us, go into schools and help out. So our social medias are on there. Feel free to check us out. And on that note, take it away.
Thank you. So, as has kind of been said, I live and breathe neurosurgery. I like it a lot, and that's where I need to be because I'm going to be applying for it. But I anticipate in this talk, the audience is going to be a split of people looking at it for F1 or F2. There will be some people who may also want to apply. There may be some people who have a little bit of trepidation about neurosurgery and the kind of emergencies and patients that we see. And a lot of you will be somewhere in the middle. So I'm going to focus more on the people in the middle or the people who've maybe not had the most exposure to neurosurgery and try and as much as I can within the scope of this talk and the time that we've got, try and equip you with enough tips and tricks, enough context to sort of really thrive in the rotation, no matter kind of what your interest in neurosurgery may be. So just as a quick primer, so neurosurgery is very busy. There can be quite sick patients, but some people really enjoy it. Other people, it's just another job. I liked the way that a friend of mine put F1 when he was in your shoes, sort of looking down the barrel of it at the end of med school, when he said, I'm looking forward to the best, worst year of my life. And obviously, in my neurosurgery rotation, I got to do a lot of projects. I got to publish some research. I got to talk about it at different conferences. I got to operate. I learned a lot. But at the same time, there were challenges that came through that night shifts. So the on the left is sort of the good things, and on the right, they're not so good things. So there's me looking a bit suicidal, as my sister said, midnight shift. There's all of the reading that you have to do in order to kind of understand things. And the top right is some soup that a nurse made me after a patient herniated in front of me when I took them to CT. So there's it's a really dynamic environment. It's very senior led, so there's a lot of senior support. People don't expect you to be making these kind of outrageous calls by yourself. But on the other hand, if you've got an interest, you will be supported. And if you don't have an interest, that's absolutely fine. And hopefully through this talk, your local inductions and things, will give you a bit of a foundation to regardless of your level of sort of buy-in into neurosurgery to enjoy the rotation. So if we could move on. So in terms of the expectations, even though neurosurgery can be a little bit niche, um, in many ways it's just a straightforward surgical job. So, you'll come in, it's 7:30 usually, depending on the unit, and you'll go through the operations that happened overnight, any sick patients, anything that needs to be done, just like any other job. You'll have a ward round, which I'll go through in a bit more detail later, but it's a surgical ward round and a surgical specialty, so quite speedy. Like any surgical job, you'll especially if you want to. There'll be some things that you kind of just have to get good at if you're doing a surgical job, like managing people's anticoagulation during admission or their diabetes medications. The more surgically minded of you might really want to get involved in some suturing if a wound's leaking, and you'll gain confidence as you do that, as you see some neurosurgical presentations, including emergencies as well. Um, Neurosurgery as a service nationally tends to be clustered into tertiary centres. So I can never remember exactly how many there are of them, but there's less than 20. So in Nottingham, where I've spent the most of my time, we accept referrals from all over the Midlands. So as well as discharging patients when they're ready to leave hospital, a big part of your job will be what's called repatriating patients. So it's a form of discharge, but you're sending them back to their local hospital that doesn't have neurosurgery. But discharge is really important because these beds are precious. So Nottingham has about 70 beds, and our catchment area is 3.5 million people. So getting people through is important. I know you'll get to a point where you roll your eyes at the idea of patient flow and bed managers getting on your case, but it is it's good to bear that in mind. Also, surgical TCOs are really easy because they come in, we fix the problem, and they go home. And another thing that you'll be encouraged to pick up, and you'll naturally get there through osmosis anyway, will be having a kind of basic awareness of kind of what we've done to patients. We'll put bolts into their head, we'll put drains there after operations. And your jobs might be, if you're an SHO, particularly keen F1, to take them out. So knowing your way around them, how they work, where they sit anatomically, will form part of your role as well. The most important thing, and I'll bang on about this throughout, is please, please, please talk to your registrar if you're ever unsure, out of your depth, you think something's not quite right, because they want to know, and they'll help you. We can move on. So in terms of seeing new admissions, in this presentation, I'm not going to read through absolutely everything because it's being recorded, and I don't know if there's a plan to share the slides as well. So I don't want to just by rote tell you everything. So I'll give you a bit of a flavour, also in the interest of time. So the thing about neurosurgery admissions is it can be anything from, as I've said there, somebody who's got a really small brain tumour. It needs a biopsy, but it's potentially an elective operation. They're about as much high risk as somebody having the most boring hernia operation. Okay. On the other hand, this could be somebody who was admitted to an ED, emergency department hospital, miles away, been sort of managed for a subarach, and then sent to us or to you. And, you know, they're kind of, from the sending hospital's point of view, it's kind of the end of the algorithm. Get neurosurgical advice, send them there. So if I ever get a tap on the shoulder from the nurse in charge says you've got a new admission, one of the first things I ask is, are they vascular? As in neurovascular, so something bleeding. Um, Not to say that that's the only time critical neurosurgical pathology, but it's just good to get a sense of, don't leave somebody actively bleeding in their brain thinking, oh, it's a simple clot, I'll get to it. So just try and see them quickly. Neuro examinations are kind of variable in medicine. And it's just a good idea to start from first principles. Don't just copy what the sending hospital said for power or for the cranial nerves and stuff. Just start again from the beginning. You'll have access to things like GP notes. If they've come through ED, there will be some notes. So you'll have some things to look at, but just don't, just take it from first principles. And sticking with that theme of first principles as well, don't get overwhelmed by the fact that, I've got to exclude this, and what if they have that? And, I'm going to examine this correctly. And just remember that you're just taking a neuro history. So, remembering things like, oh, I was suddenly paralyzed on the left-hand side of my body is very different from something kind of that slowly happened over a few weeks, right? Because if something's really sudden, it's more likely to be something like a stroke or a bleed, whereas something progressive over time, maybe that's cancer. So knowing the symptoms over time, what side of the body, and these are just important little wins to sort of document. And always ask if they're left or right-handed. If you're left-handed, the speech centers are probably on the right-hand side of your brain and vice versa. So someone who's going to drill into their head wants to know where their speech centers are. Some special considerations, because again, this is a surgical job, is, anticoagulation is really important. We might have to walk it back, we might have to change it perioperatively. So it's always good to ask if there aren't any anticoagulants, when they last had them, and if they've been diagnosed with, anything like a PE or a DVT. There are some other details that are good to have about implanted devices, and that's good because, if you've got a mechanical heart valve versus a tissue one, changes how we manage their apixaban. We always want to be sure that if we're going to put somebody in an MRI scanner as well, it's something that's not going to, be pulled around by the magnet. So it's just good to, if someone says they've got a pacemaker or a stent, just ask a couple more questions. And if they don't know, that's fine. Standard sort of surgical clerking applies. So medications you care about, anticoagulants, antiplatelets, diabetes medications, time critical stuff. Just asking, even just, do you have any help with anything around the house? How are you in terms of, getting about to the shops and stuff? That is genuinely useful for, I was actually there on an on-call where we declined to accept somebody from a care home who was newly hemiplegic, but it's because they were 92 years old, very frail, bedbound already. So we're bringing them over for a major operation with risk of death if they're going to be bedbound anyway. Do you know what I mean? So, these things that might seem like, oh, I can just gloss over them, they're not important. They do genuinely help surgical decision making and then discharging them so we can move on. A few little notes about the examination. So it might seem like a lot the first few times you do this, depending on your experience with neuro, but if you just breeze through a GCS, quickly go through the cranial nerves and just, can they squeeze your fingers, do this, move their legs. Once you get good at it and with more experience, you can do it in 5 or 10 minutes. Whenever you talk about GCS to anyone who's in neurosurgery, always describe it in terms of the subcomponents. And that's because GCS 14, and it's, the subcomponents matter. So like they could add up to the same total, but if somebody say got a motor score of 6 contributing to that same total versus a motor score of 0, it can be really, it can be a very different prognosis. So always say, E3, V4, M3. And it also helps you remember as well what they are. Don't just zero in on the nervous system as well. Think broadly. You're probably more pluripotent than the registrars and consultants because you're just fresh out of med school, so you remember all of the other pathologies. So just remember to bear other things in mind. You've seen them, you've examined them, you've got a differential. You think giving Subarach, or I think they've got a tumor, but anything like that. So basics that are general for a surgical job with a bit of a neurosurgical twist are let the registrar know. Ideally, let them know when you're going to see them. They love coming to see new admissions because they're aware of how time critical things can change. That patient that I mentioned, Koning, that was on their CT on landing, and they were sent from a hospital in the city down the road. They had a Subarach. The GCS was lower when they got here compared to when they left the hospital that they were sent from. So we got another CT scan to see if they were developing a bit of hydrocephalus. And, I took them down to scan. They went in GCS 14. CT scan takes seconds. And they came up GCS 3, fitting and vomiting. So, it's always let the registrar know things can change quickly, and they know that and want to be a part of it. But yeah, just hold any anticoagulants, keep nil by mouth until someone says, oh, we probably won't operate, they can eat again. And just get the basic bloods, think if they need more imaging, prescribe the usual medications, basic stuff like painkillers, antiemetics. Subarachnoid patients need to be started on a calcium channel blocker called nimodipine. It protects them against a really serious sequelae of subarachs, which we can talk about maybe at the end or on, when we're talking about core presentations. I'm conscious of time. We can move on. So the things that you'll see are a mixture of brain bleeds, subarachs from aneurysms bursting, chronic subdurals, elderly people, saggy dura, the brain shrink a bit, pulls on those bridging veins, and they end up a bit hemiplegic and confused. Traumatic brain injury. So I worked mostly in Nottingham. The amount of people I've looked after who, they're on those e-scooters and stuff, they fall and just, you can manage a lot of them conservatively, but sometimes they'll be on ICU. But yeah, you'll see a lot of that. Hydrocephalus, so pressure, fluid building up in the ventricles. It can get a bit nerdy in terms of, oh, is it this kind of hydrocephalus or that? But it's a problem of pressure that we fix by putting a tube in, which we'll talk about when we get to procedures and surgery and stuff. You can get infections, your meningitis, encephalitis, abscesses. This is in a later tips and tricks slides, but generally speaking, for infections that affect the nervous system, you can expect people to be on higher doses of antibiotics than you're used to seeing, for longer courses than you're used to seeing. It's just because they're a bit more serious and can get techie quickly. Tumours, so neuro-oncology is a big part of the work, whether that's just biopsying people so that they can be discussed in NDT or removing the tumour. Different units will give the degenerative spinal problems to the orthopedic surgeons, or some units will do them themselves. And then finally, in recent years, treatment for things like Parkinson's, we can put electrodes in people's thalamuses. If they've got spinal problems, we can implant electrodes into their spine as well to help with that. So they'll often come for battery changes, changing the devices and things. So there's a wide range. We can move on to the next slide. In terms of the things where if a nurse says this, or if you suspect this at all, you should just go. It doesn't matter what you're doing, unless you're with something equally serious. You should just go. In terms of presentations, so the nurse says, "Oh, 4-1 is or red 5," whatever the bed system is where you work. They've dropped their GCS. Just go and assess them. Do an A2E. We'll talk about that a bit later in terms of how to go about assessing neuro patients. Do an A2E, examine the pupils, do a GCS, and just go and see them, because that could be something really, really serious like hydrocephalus, raised intracranial pressure, a rebleed. So just go and assess them. Same thing with seizures. It'd be a good idea to double check where you're working. Every hospital has their own kind of protocol on how we deal with seizures and status epilepticus. So knowing that, okay, at 5 minutes I'll give this, or at 3 minutes I'll give this, whether it's lorazepam or buccal, whatever. But generally speaking, I got to a point by the end of my neurosurgical job where, okay, they're seizing, make sure someone's timing it, make sure there's a sat probe on to make sure they're not desaturating, and load them with Capra. So, you get used to these things very quickly, but it's just worth checking where local practice varies as to the order and timings of different medications for seizures. For a new focal deficit, what I mean by that is, somebody was normally fine on that side, they had 5 out of 5 power, and they're a bit hemiplegic on that side. And again, that could mean a new kind of stroke, a rebleed from an aneurysm. It could mean something quite serious. So it's always a good idea to go and see those people straight away. And lastly, anything to do with like pressure or hydrocephalus. So what I mean by that is, people might start, and they have to kind of like fit the bill for it, right? So this might be somebody with a space occupying lesion. This might be someone with blood in their head. So you kind of know, okay, that's that patient. I know them. They've got a reason to have raised pressure. If they just come in for a battery exchange on their spine, this maybe isn't relevant. But if they start vomiting, really bad headaches, blurred vision, drop GCS, those are all, go and see them very, very quickly. And you'll probably end up doing a CT head for all of these. In terms of specific kind of, not so much, oh, this patient started doing this, more kind of like a complete picture. So specific complications or syndromes. We've talked about raised ICP already. I mentioned that we go back to this. So when somebody's had a subarachnoid hemorrhage, they're the closest thing that you will get in a ward environment to basically giving ICU level care. These patients remain critically unwell for weeks, up to a month afterwards. And, the really high risk of developing really catastrophic complications. So if they've had an aneurysm that bled, it might rebleed. Blood gets mixed in with the ventricles, and then the CSF can't absorb, so they can get hydrocephalus. We really care about sodium in neurosurgery because of it's to do with the pituitary and the kidneys and autonomics and stuff like that. But basically, from your point of view, patients can become really hyponatremic really quickly. That in itself can kill you. So it's just a really good idea to keep a close watch on those U's and E's. We can talk later about. Oh no, it's down there anyway. So yeah, so what to do if somebody drops their sodium is essentially it comes down to one of two diagnoses, something called cerebral salt wasting and something called syndrome of inappropriate ADH. The difference is often down to the fluid status. So it's really important to just, check the mucous membranes, skin turgor and all that, and document that fluid assessment. And the investigations are a fresh U&E. We sometimes call them paired osmolalities, but it's just a urine test and a serum test. And another urine test to look at the sodium. And it's important to send these off at roughly the same time. If you do one in the morning and one in the afternoon, you can't really compare them. So we can probably move on. In terms of what your week might look like, it's really variable. So some units are a bit more old school. They have the old firm model that medicine used to have, where, so for example, in Oxford, I'll be part of the neurovascular firm where one or two, consultants will basically just do brain bleeds. They'll have a registrar or a fellow, and they'll have an F1 or an F2 that's attached to them, and they just see that pathology. Same for hydrocephalus or functional or whatever. At Nottingham, it doesn't work like that at all. Everyone just kind of works generally. So your experience might differ. Most units, as I've said, start quite early. It's really important for your well-being to leave on time. I was terrible at it as an F1, but there's always somebody to hand over to. You can normally, if you know you've got an SDL day or some annual leave coming up, you can normally see what's going on and in theatre on that particular date. So if you're particularly keen to go and do a burr hole or go and see something, you can usually work out what's going to happen on what patient under what consultant, so you can start saying, oh hey, do you mind if I scrub in? Or you can swat up on the patient a little bit, people like that. And again, if you're keen, there's MDTs and there's outpatient clinics to go to. But they're very, very busy places, neurosurgical units. So hopefully you go to a good one where you've got protected time. But it's your experience may vary. Next slide, please. So in terms of the ward round, as I said, we come back to this. So surgical rounds go by really quickly. They just see a patient, yeah, they're moving all four limbs, yeah, they're probably fine, and then they go off muttering some plan. Your job is to turn that into something that's legally defensible, protects the patient, protects yourself and your team. So you will get into the swing of it and learn how to document quickly. I've got an example on the next slide, which we'll see in a minute. But don't be afraid to dig your heels in. I've done that once or twice where I've said, no, I'm sorry, I'm not finished. We need to, so it's quick. You'll get used to it in part, but if somebody is, disappeared and you've got half a plan, if you don't know what the other half of that plan is and then something happens, you end up in a difficult situation. So don't be afraid to just say, no, I'm sorry, I just need to finish this. Again, different units will do this differently, but neurosurgery has a lot of patients in peds and ICU. In Nottingham, the registrar just goes off and takes care of that by itself. In your unit, you might be expected to go with them, so you might see some different patient populations. We can move on. So this is just an example. It's just one that I've made up. It doesn't have to, we don't have to go through it in detail, but I found having in my mind the same kind of headings that are right for every patient helped me kind of go on autopilot, always be sure that I've kind of documented what for me was the bare bones that I needed to put for everybody, and just helps me just be quick and efficient and not miss anything. So I normally write a line or two of the background. There are 70-year-old woman who's come in for a subdural. They've got something going on in the past medical history, so we don't lose track of them in the admission. What are we bothered about at the moment? That's the problem list. Investigations, making sure that the bloods are normalizing, if they've had any imaging. Some stuff when we've gone to see them, so on examination, they're not noosing. We've looked at the GCS, we looked at the power in their limbs and stuff. So this is all kind of the stuff that you see when you go and actually see the patient. And then the plan, and then signing it. So you don't have to write reams and reams. Just making sure that you covered the essentials. Should be absolutely fine. Can move on. In terms of common tests that you'll see in neurosurgery, so imaging, we image a lot of our patients a lot of the time for good reasons. So as I'm sure you remember from med school, sort of CT is good to quickly check for blood. MRI is more useful for getting that high spatial resolution on sorry, I was just checking that message. High spatial resolution on soft tissues, so the brain and things like the jaw that go with it. So you'll be asked to do a lot of CT heads, and you'll do them when you go and see acutely unwell patients. They're normally quite straightforward to request, but we'll talk about radiology towards the end and how to make good scan requests that don't get rejected. For CT as well, you can also get a CTA, so a CT angiogram, so that's contrast injected that lights up all of the vessels nicely, and it's a good way of looking at things like aneurysms or malformations that can cause issues. For MRIs, you mostly use them to look at people who have cancer. MRIs with contrast are a good way of looking for disease recurrence, so people tend to periodically get them in the community. You'll do one after you do an operation on them. So they're usually MRIs with contrast, but always check. And MRIs are also great for looking at infections if someone's got a head full of abscesses and things like that. You might be asked for an MRI to ask for specific well, they call them sequences, but it's just the way that they program the scanner and what they tell it to do. So your registrar might turn around and say, oh, can you have an MRI with MP-RAGE sequences, with CIS, with blah, blah, blah. And you just have to if you don't know what that is, and if you never heard of it before, just ask them, because those sequences will be sort of, their settings will be something that captures something specific that's important for the operation, for evaluating the anatomy and stuff. So and this is true for all scans, if you're not 100% sure to the point where you could, if the radiologist phoned you and asked questions, if you're not 100% sure, just ask. And similar to CT, MRI can also be used as an angiogram. We don't tend to do that as an inpatient. We tend to more use CT, but it's just so that you're aware that, angiograms exist in both modalities. Can we move on? The last sort of big investigation to sort of talk about is CSF, cerebral spinal fluid. So there are generally two contexts where we'll be sending CSF off. The first case is where we know that what we're getting is CSF. So if somebody's got a drain or a shunt, we will take a sample from that. And we're usually looking for, things like infection or things like that. So in that case, we've performed essentially a sterile bedside procedure to get this CSF. It's difficult, and there's a real risk that we introduce an infection. And if you get, so obviously CSF is produced in the ventricles of the brain. If you get ventriculitis, it has something devastating, like a 60% mortality. So we'll do it if we have to, but we're really careful and really aware of the risk when we sample CSF. All that to say, if we give you a bottle of it, just treat it as precious, because we've exposed the patient to a lot of risk to get it. It's it's a bit long as a procedure getting it, because you have to do it in a specific way. So just don't drop it or lose it. For most micro investigations, you'll be putting things like, we're treating for this infection, this culture's shown this, they're on these antibiotics. So it's just always good to mention those. Get somebody to hand deliver it to the lab as well. Like I said, it's precious. Don't put it in the pod and it explodes. So we know it's CSF. We want to answer a question about it. The other context is you've got someone who say they've had pituitary surgery, they've had skull-base surgery, they've had trauma to the base of the skull, and they've got a bit of clear fluid coming out of the real nose. And we want to know if it's CSF, because they have to go back to theatre. It's a whole rigmarole, because if something's open to the outside, it means bacteria can get in. There's a test that we do on this fluid that is called beta transferrin. Your unit might be different. I'm going to say that a lot in this presentation, sorry. For us, we have to basically, once we get the sample, we call the lab and say, hey, we are, we're going to send you this and you need to analyze it ASAP. The reason why, other than these being precious samples, the reason why speed is sort of an issue is that they can degrade quite quickly, and then the information isn't really useful. So it's just about avoiding, giving useful information in the request, treating them as precious because they're a pain in the ass to get, and just avoiding situations where they sort of sit on the doctor's office sort of desk for 4 hours and go bad. Yeah, that's probably everything to say on CSF. We can move on. So procedures and practical skills. So whenever you do something, well, I should say to start with, you should never feel pressured to do something that you either don't feel comfortable doing or don't want to do. There's an argument that you need to be proficient in some skills and pick up something from having this, but there's quite an old-fashioned view and there's limits to it. So don't be pressured into doing a lumbar puncture if you don't feel confident doing it. If you do anything like this, it's a DOPS. It's an easy win for your HORA, so make sure to get an email and get a sign off for it. So really easy things that F1s and F2s can do is so these pictures here are of a subdural drain. So if somebody's had an intracranial operation, say to drain a subdural hemorrhage, when we put the dura back together and sort of close everything on our way out, we'll leave a surgical drain that's in between the dura and the brain. That is just because, there's a surgical site that will bleed a little bit. We don't want it to collect and, cause the same issue again. So they'll have a drain that's coming out of their skull for about 48 hours. Once that's done its job, it's a sterile bedside procedure. You just paint the head in chlorhexidine, get a sterile kit out, and if you look at the picture on the right there, you basically see you've draped it, you've painted it, and you basically just cut the sutures that are holding it in place. Gently pull it out. If you feel resistance at any stage, stop and get your registrar. And then finally, you're looking at a hole where the drain was. Okay, you, depending on how big it is, you'll throw some sort of suture in there to close it. And this is really, really important for any time you take out a subdural drain or anything that's been in the cranium. You have to ask them to cough at the end. And the reason for that is it's a Valsalva maneuver, and we need to have a watertight seal for the dura. If it's a bit open, as I said, if it's open to the outside, bacteria can get in. So you'll ask them to cough, and one of two things will happen. Either nothing, or you'll get kind of like a reflux of like dirty motor oil. It's kind of like a brownish red thing. That means you're seeing a mixture of blood and CSF, so it means that your suture isn't watertight, and you maybe need to do another one, or at least discuss it with the reg, depending on how confident you are. But if you ever take something out, just get them to cough at the end, and if you see a splatter, it means that it's not closed properly yet. Those aren't the other wounds that you'll suture up. Somebody could have a cranial incision, they could have a lumbar incision if we've gone in their back, and it might be leaking a bit of blood or something, so you can just bang a quick stitch in there. And lumbar punctures as well. We maybe don't do them as much in neurology, but we do them on the ward. And if you want to get trained up to do that, it's a great skill to be able to learn and do. We can move on. In terms of the operations that we do most commonly, this is just a quick primer, so you are familiar with the sort of language used. If someone says, the day 2 after a VP shunt, if you've never seen one of those before, you have some context. Again, I'm a bit pushed for time, so I'll just quickly sort of talk you through the pictures. So on the right there at the top, you've got somebody who's had 2 burr holes drilled in their head. That's to evacuate a subdural. So you basically just incision, retract, burr hole, open the dura, and just irrigate it until it runs clear. And that's what you're seeing in a picture at the top and in a real person at the bottom. If we move on to the next slide, there's a couple of other pictures as well. So top left, you've got the landmarks to put in what's called an EVD, or an extraventricular drain. This is basically a tube from the outside that basically goes, so you've got a burr hole, you poke it through the brain until it goes into the lateral ventricle. There's really specific landmarks to that procedure, but that's basically all that is. So they'll have a drain coming up their head that's draining CSF. If we look at the bottom left, somebody's having something very similar. They're having an ICP bolt put in. So this is just basically, we make an incision sort of about here. We use a hand drill for this. And then we basically just put a special wire inside the brain. It's the only real way to measure the pressure inside the brain without guessing. It's kind of like the brain equivalent of a arterial line. In the middle, you've got a VP shunt. So it's VP because it starts in the ventricles. So you have an incision here. Here for the camera. You basically do the same thing as though you are putting an EVD in. You basically put one end of the tube into the ventricles, and basically under the skin, subcutaneously, you tunnel all the way until the other tube drains into the abdominal cavity, where it just gets reabsorbed. And that's for somebody who's got hydrocephalus. And then the very last thing to tell you about is craniotomy, one of the very, very fun operations. So craniotomy is just, you need to make a window into the skull if you want to get into access anything in the brain. The way that happens is you basically make a number of burr holes, and then you get a slightly different drill and you just connect them, and then you can just take it out, you open the dura, you do what you need to, and then you take the same plate, you put it back and fix it with some screws. So I've put all of that in words on the previous slide. There's some pictures, just a bit of a glossary of the operations that we do. Can move on. So yes, this is more sort of how to think about seeing patients and stuff. And this isn't systematic. I'm not going to go through every condition and everything that you must do. These are just kind of some general principles, some tips and tricks that have been sort of useful for me and people that I've worked with. So as we kind of talked about, neurosurgical emergencies can seem scary if you've not necessarily seen a lot of them before. If somebody says, "Oh, bed 4 has they've been seizing for 4 minutes, it's stopped, but now the GCS8, that's, unnerving. But they're often straightforward and simple when you get used to them. A great registrar once told me all of emergency neurosurgery is just pressure management. They're very, very simple equations. In the same sense, the things that you'll get asked to come and see, straightforward, even if they're intimidating. As I banged on about, day or night, discuss anyone who's sick with the registrar that you've been told so and so is your registrar who's covering the ward. They want to know and they want to be involved. As I've said before on clerking, just remember other organ systems. Don't necessarily hone in on the neuro stuff. Somebody could be a bit lethargic, a bit drowsy, and then, as I've said here, be septic or hypoxic or low sodium. Surgeons are surgeons, and you are a pluripotent F1 or an SHO who can think more widely, especially if you're by yourself. Don't be scared to put out a medical emergency call, contact the med reg. If you're worried about an airway emergency, say the GCS5, don't be scared to call an anaesthetist. Even if you've got a rude senior who makes a bit of a whatever comment, as a basic principle, you can't really be criticised for acting on the information that you had and trying to keep the patient safe. As I've said before, anything that's open to the world lets bugs in. So anytime someone says, "Oh, this wound's leaking," you should go and see that quickly. Even if it's to escalate it to the registrar, hand it to somebody else. Don't let it. I was going to say don't let it fester, but yeah, literally fester, bacteria in that. And you'll get a lot of taps on the shoulder because people become acutely unwell quite quickly. Somebody might just drop the GCS, they might just become paralyzed. So you'll have a lot of interruptions in your day. And you'll have new things come up on your job list. It's not the kind of specialty where you make a nice, neat jobs list in the morning and you just go through it methodically until they're all done. You will get new things added to that. It's important that you get through them all still, and that you hand over what's left at the end. But what's most important is that you're always targeting the most important things first. If somebody has been asking for laxatives, antiemetics for an hour and the nurse keeps coming to get you and you're busy with somebody who's making a really good go at trying to die, it's sad, but that takes priority. Maybe somebody else can help, but don't be afraid to be ruthless with your triaging. You have to see the most emergent. There's only one of you and you have to see the most urgent thing first. We can move on. So I want to wind things to a close in the next couple of minutes, so I'll slightly speed up on these things. The main point with opportunities for portfolio building is, as I've said, I anticipate there to be a range of kind of interests in the people that are doing this job. But I would encourage you to, even if you don't want to do neurosurgery, just be creative and think broadly about how it can help your career, because we see a lot of patients with serious infections. We work incredibly closely with pathology to do the biopsies on our brain tumors, infectious diseases. So there are common pathologies to neurology. There are common things that we share with ED. It's easy to make a surgical thing sort of perioperative themed if you're more kind of anestheticsy inclined. So just don't necessarily if you need a project, don't necessarily think you can't get there in neurosurgery. And that picture on the right is just for the keen beans who want to do neurosurgery, just with a reminder of kind of like the things that they need to be building. Yeah, we can move on. For your well-being, I've talked about some of this already. So there's a concept of minimum staffing on the ward. So it would be an agreement buried in some policy somewhere that there needs to be 3 doctors on such a ward, for example, for it to be the legal minimum for safe working. And there will be times when you're not at minimum staffing. Either somebody's called in sick, and the rota coordinator may not know, the ward registrar might not know. You shouldn't be put in that position. The department should be advertising aggressively for a locum. They should be moving people about if there's somebody on another ward who can come and help. So just escalate that. Don't accept that you just have to do 2 doctors worth of work. Unless you are, so there's one time where it was 5 to 5. I had somewhere I genuinely needed to be, and there was a traumatic brain injury patient. We were managing conservatively, and at 5 to 5, he popped off with a blown pupil and a new focal deficit. I still managed to get to what I needed to get to in the end, but of course I had to go and see him. Situations like that are really the only time you should be staying late. There's always somebody to hand over to. It's unless it's a genuine emergency, in which case, just get the basics of a plan together and then hand that over to the night doctor. Don't get stuck there for hours. Even with the bowel obstruction that I was dealing with today, I saw them, I made a plan, I made sure that everybody understood the plan and that somebody was going to be coming to see them, and then I went and then I came to do this. If you do stay late, exception report. It's the only sort of ammunition that anybody has to make changes. In my training, people have subsequent trainees have had better rotas, better staffing because people have been exception reporting. It's the only thing that management listening to. Take your annual leave. It's easy to put off organising it, and then it gets tricky to book when you want to have it. Stay in touch with your friends and family, and some of this might seem a bit, oh, I'll be fine, but there can be some, you'll have bad days. You'll have lonely days. You'll have days where you've seen something that's, you're still processing. So just above all, just make sure you're looking after yourself. And if you think it's just one of those days and it's staying for weeks, go and, however you get support, get support. We'll probably move on. So I've got one or two slides of just some general kind of thoughts. So the first slide is mostly kind of useful people to be able to call because you might need to talk to these people quickly, or you might often need them. So we won't go through all of them in the interest of time, but these are just good people to, you might have an app that your trust uses. You might have just, save them in your phone, whatever. Just be able to call these people in quickly. There's a lot of MDTs in neurosurgery, so brain cancer, neurotrauma and stuff like that. There's often like this random person that you have to email, this weird form that you have to fill out, and then some rule that, the cutoff for discussion each week is before 1 p.m. on Wednesday. It's just a good idea to just know roughly what that information is. So, I need to refer them to school-based MDT. Oh, it's this email. Oh, it's Monday. Great, they'll get discussed this week. Just to get to that point with it. If somebody's got a shunt that connects their ventricles, and it can be any part of the body, but it's mostly the abdominal cavity, you might get asked for a shunt series. It's just a collection of different X-rays to look at, the entire tract of that, tubing to look for any breaks or problems and stuff. Can move on. There's a note on sort of you're prepping someone for theatre, what that means. So bloods, by mouth, holding their enoxaparin the night before and prescribing them like some fancy wash that gets rid of MRSA. People asking for driving advice is really, really common. There is a link there to basically the government website that shows, oh, they've had a TBI, this is a driving advice. Oh, they've had a seizure, this is a driving advice. I don't know all of these off the top of my head, but it's just good to, it's a good resource to refer to. A lot of the patients won't be suitable for Clexane because, we'll be operating on them and things like that. So, but having some VTE prophylaxis is really important. One thing that can make you really scared until you catch yourself is a lot of the patients are on steroids, and that drives up the white blood cells and the neutrophils. The CRP won't be affected. So if you see someone with white cells of like 18, just check the CRP. Steroids also pump up your blood glucose, so just keep an eye on those BMs. If they've had a pituitary tumor removed, so like a adenoma or something, there's a few extra bloods that you might need to ask for. And you might need to get endocrine or ophthalmology involved because you get that bitemporal hemianopia. When somebody comes in for a biopsy, even if it is, and your unit might be different, but even if it is a barn door obvious glioblastoma multiforme, the time and place to have that conversation is in the consultant's office with the cancer specialist nurse, and take as long as that takes. It's usually 45 minutes to an hour. If you step up and put GBM on their TTO and they read it before they've had that conversation, it can be really damaging. So just be really careful about the language that you use. So often you get told to just put space occupying lesion awaiting histology, something like that, right? If people are being discharged, if we put them on steroids, we need a plan for taking them off. If they came in on anticoagulants, we need a plan for restarting them. I've already mentioned CNS infections. Can move on. One of the last things I wanted to mention is just scans. Sometimes people are a bit nervous about that. Sometimes radiology, push back on things. Just some general principles are, neurosurgery and radiology often get on. They know that we, for good reason, need a lot of CT heads, and they know that there's probably a good reason. And in return, we try not to take the mick. we try and write, decent scan requests that, have a specific clinical question, some information about the patient. Good tip for neurosurgery. Often these scans are needed very quickly. The way to make a scan happen very quickly is to phone the radiology registrar who's on call, whose job is to, amongst other things, is to vet these scans and sort of say, yeah, yeah, no, yeah. Just have a quick conversation with them. Just say, you're all right, I'm one of the neurosurgery doctors, just want to discuss the scan. A sentence or two of why you want to, what you're worried about. 9 times out of 10 on neurosurgery, will say, yep, get that vetted. And then you call the radiographers and they say, they're the people who say, bring them at 2 o'clock or we'll send the porters now. So just phoning radiology and the radiographers to get the scan approved and then a slot for it. And even if the scan hasn't been reported, if the images are on PACS, just tell your reg because we can read scans to just obviously not to the same thoroughness of the radiologist. Can move on. That might be the end. Yeah, that is. So I'm sorry that was first of all, thank you for your patience. I'm sorry that was late dealing with that emergency. I'm sorry that we rushed things slightly for time, but we have enough time for maybe 1 or 2 quick questions.
Many questions as people want, and as it says here, please do the feedback, and we will send out the slides to anyone who completes it. I can't see the chat, okay, so feel free to, if people ask questions, take it away.
Yeah, sure. So I can't see anything at the moment. I'll wait around for a bit. I appreciate that there might be a few people live, and there might be people who are watching the recording. So there may not be any questions, and that's fine.
Yeah, and if people watching the recording have questions, feel free to put them in the YouTube video comments, and I will email them over to Caden. I'm sure he's happy to reply to them.
Yeah, more than happy with that as well.
Amazing.
We might be good then. So yeah, very whistle stop tour. Happy to answer any questions after the fact. Thank you for coming.